Good afternoon and welcome everyone to today's edition of Black Health Trust. We're so happy you chose to be with us this afternoon, and we are looking forward to a very informative discussion about something very important in our regarding our health. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone, and thank you for joining us. Thank you, Dr. Barbara Davis Stevens, Dr. Ivan Wilkes, and Dr. Lawson. I don't think Dr. Hines is with us today, but I wanted to do something a little bit out of the ordinary and unauthorized, but I think it's approved. Many times we have honored in the past people who have played a part in Black Health Trust and have passed on. But I wanted to take the different tack today and honor someone that is extremely well respected. He's current and he's loved by many. And I want to give an honor and tribute to our own Dr. Richard Williams. Can we do our first slides? And the title of our talk today is The Heart of the Matter, which he coined some time ago as a good friend of mine. You put up the slide, Simon, if you would, please. So I'm calling this The Heart of the Matter, a clear guide. It's very important that we take into account what we do about our heart health. And this is something that won't be very scientific, but it's something that is very much needed in terms of how you take care of yourself, how you interact with your caretaker. But first, I want to honor Dr. Richard Williams, MD, SCD, and FACC. Next slide, please. So Dr. Richard Williams is the founder of the Association of Black Cardiologists. He's a visionary physician, an educator, and leader. This comes from the literature I had reviewed for this. His early life and education was Harvard University. He got his Bachelor of Arts, cum laude. He graduated from medical school at State University of New York, Downstate Medical Center. He did a cardiology fellowship at the Brigham and Women's Hospital at Harvard Medical School. He was assistant dean of Harvard University College of Medicine and director of the EKG lab. He was an early advocate for diversity and inclusion in medicine before it was so popular with some of us who have good sense. He was a founder of the Boston Central Recruitment Council. He's the founder and director of that in 1969, and I was one of his early recruits. He collaborated this effort at Harvard, Boston University, and Tufts University. He opened doors for underrepresented minority trainees. He led the first wave of Black residents and fellows in Boston teaching hospitals. Next slide. Go to the next slide. So next slide. And he's known for building institutions for equity. He helped open the Martin Luther King Community Hospital in 1972. He co-founded with Dr. David Satcher and directed the King Drew Sickle Cell Center, and later founded the Minority Health Institute, which addresses racism in medicine. Next slide. So he founded also the Association of Black Cardiologists in 1974 and actually invited me, a nephrologist, to be a member. He founded the ABC to eliminate cardiovascular disparities. He served as the first president from 74 to 1984. He created national scholarships and programs for Black medical students. And he also has the the Association of Black Cardiologists Scholarship established in 1980, which has helped many Black students get into and finish medical school. Next slide. His academic and national leadership record includes as the first African-American professor of medicine at UCLA at the David Geffen School of Medicine. He was the chief of the Heart Station at West Los Angeles VA Medical Center. He was the 117th president of the National Medical Association from 2016 to 2017, and has been an advocate for healthcare equity and systemic reform. Next slide. So he's a pioneer and author as well, and a thought leader. He wrote the textbook of Black-related diseases, which he graciously allowed me to do a chapter, number 15, if you're interested. This was published in 1975. It's the first of its kind. He wrote a book on healthcare disparities at the crossroads of healthcare reform. This was published by Springer in 2011, 2014. He wrote a book called Blacks in Medicine, which was produced by Springer. He also provided the scientific foundation for understanding race, equity, and health. Next slide. But of most important, in my mind, he's been a mentor and helped pipeline development for students of color, Black and brown. He has mentored hundreds of students into medicine and health sciences. He had the Boston Council alumni physicians, became physicians, leaders, and scholars nationwide, along with Dr. Alvin Toussaint, which many of you know, Dr. Vivian Penn, and Dr. Pendergrass. He also has the ABC and AMA scholarship to continue his mentorship legacy, and also has helped students in the school. He's been honored by the American Heart Association with the Lewis B. Russell Award. Next slide. The AMA Testimonial and ACC Diversity Leadership Awards, the Harvard Lifetime Achievement Award, and the Wilmington, Delaware street was named in his honor in 2024. Next slide. So his legacy and continuing impact are important. He's a true architect of equity in medicine, elevated minority positions, presence in academic and clinical cardiology. His voice endures in the work of the ABC, the NMA, the AMA, American Heart Association Minority Health Institute. He's inspired generations to lead with compassion, courage, and conviction. And I am one of his acolytes. So in tribute, Dr. Richard Allen Williams has shown that one who is determined and a physician can open the doors of medicine to thousands. This tribute is from the Black Health Trust as the CEO and founder. Thank you, Dr. Richard Allen Williams, for your service, mentorship, and legacy. Your life's work continues to heal hearts and inspire minds. And this is from me, your student, and your acolyte, Randall Maxey, MD, and I hope the rest of us join in congratulating Dr. Richard Williams for a lifetime of work for our profession. Thank you. Is Dr. Williams with us today?
Yes, he is. He is sitting there just taking it all in, as he should.
Dr. Williams, you have a brief period you can respond, which I know you're too bashful to do.
We need to get his mute taken care of. Can we get you to unmute, Dr. Williams? There we go.
There we go. Well, who is that masked man that you described? Thank you so much, Dr. Maxey. And hello, everyone.
Hello.
I'm humbled, indeed humbled by your presentation and your tribute to me. Totally unexpected, but very much appreciated. So I don't know what I can add to what you said. Certainly not anything in regards to the accomplishments and so forth. I want to say that I not only appreciate your doing this, but also mention that I know that you do it out of a sense of, I'm just joking here, uh, kind of jealousy in regards to fact that nephrologists are always playing second fiddle to cardiologists in regards to our importance in the impact that we make in medicine. I'm just kidding here, but I note that you titled this The Heart of the Matter and not the kidney of the matter. I want to mention that we cardiologists have decided to induct nephrologists into our surroundings and our and into our efforts to try to save lives by creating this new approach, which has the title of cardiac, kidney, and metabolic syndrome emphasis to try to focus on the principal causes of disability and death, morbidity and death in this country. And so we've finally included nephrologists into the mix, and I'm sure that you're happy with that.
Well, thank you very much. And I will say that kidneys don't kill you, but they make your heart kill you. Thank you very much. We got a lot of slides to go through, so you can listen to your inspired lecture. Let's go to the first slide. And you're welcome to comment as we go along.
Certainly.
Next slide, Simon. And thank you, Dr. Williams, for being such an inspiration.
Thank you.
So how a healthy heart works. Imagine 4 rooms that move blood in the right direction with the help from valves. An electrical signal tells the heart when to squeeze and open blood vessels, and a strong squeeze keeps the body supplied with oxygen. Next slide. So blood flows from the body into the right atrium, then through the tricuspid valve into the right ventricle, then through the pulmonary artery to the lung, then to the left atrium, and through the mitral valve, and into the left ventricle, and into the aorta, and to the body. Next slide. So imagine these 4 rooms, starting on your left-hand side with the right atrium, going to the right ventricle, to the lungs, to the left atrium, and to the left ventricle and squeezes. Next slide. So heart failure is when the pump is weak or stiff. The heart can be too weak to pump enough blood, or it can be too stiff to fill early between beats. The signs might include shortness of breath, ankle swelling, and low energy. It's very important that you notice these signs and don't just say it'll get better later, but find out what's going on now and see your primary care doctor or your cardiologist, but make sure. So care can include water pills or medicines that reduce strain in the heart. It's very important, and being a primary care doctor now, even though I'm a nephrologist, it's important that if your doctor prescribes you medicine, don't stop them or change them without having a discussion, because some of them are very important, even though it may be a hassle to take them. Next slide, please. So risk reduction in medicine is very important. Dr. Neighbor-Stevens, would you look at this slide for me?
Certainly. So risk reduction of medicines. Heart failure medicines, estimated reduction in risk. So if you look at the orange or mustard colored bars you'll see that they have different percent of reduction in risk. We have two that are really tied. The middle two, beta blockers, which you've heard Dr. Maxim mention many times, and mineralocorticoid receptor blockers. On the extremes of the graph, left and right, we have the ARNI type medicine and the SGLT2 inhibitors that we talked about last week.
Thank you, Doctor. So, Dr. Walsh, will you take the next slide?
Absolutely. An enlarged heart, high blood pressure, and valve problems can make the heart grow larger. A bigger heart can be weaker and cause rhythm problems. Tests include an ultrasound of the heart and sometimes magnetic resonance imaging, or MRI. Treatment targets the cause and also protects the heart. Next slide, please.
Go ahead with that, Dr. Walsh.
All right, irregular heartbeats. The heart can beat too fast, too slow, or unevenly. Atrial fibrillation is a common rhythm problem that can raise the chance of a stroke. Treatment includes medicines, procedures, and sometimes devices. People at higher stroke risk may need blood thinners. Next slide.
Is Dr. Lawson with us?
Yes, he is.
Hello,
Sure
Dr.
is.
Lawson.
Well, I guess the slide is showing that atrial fibrillation increases stroke rate. On one quant, it shows chance of stroke. And
So with time, the risk increases for a stroke, which can cause mental health problems, as we'll see later. Next slide.
absolutely.
Take the next slide, Dr. Lawson.
Chest pain from poor blood flow. Pressure or tightness with activity can mean low blood flow to the heart muscle. Testing may include a stress test or a special CT scan of the heart arteries. Treatment includes lifestyle changes, medicines, and sometimes stents or bypass surgery.
Okay, Dr. Neighbor-Stevens.
Heart valve problems. Heart valves, and you remember from the earlier slide, that's the passageway between the upper and lower chambers. The valves can become tight or leaky and cause shortness of breath and swelling. Some valves can be fixed or replaced with a catheter procedure or by direct surgery.
So calcium score and the extra workload from high blood pressure is important. So using a CT scan, you can measure calcium in the heart and arteries. And the higher the score is, the more at risk you are, especially over the 10-year period that we evaluate those. So high blood pressure makes the heart work harder and can thicken the heart muscle. If you imagine water in a hose with a nozzle at the end, the harder that water comes through there, it makes higher pressure into the blood vessel system. Let's go to the next slide. Next slide. Next slide. So this is a slide that shows a 10-year chance of stroke growing larger. The higher the score is, it just shows that that's something we want to avoid. So, Dr. Walks again.
Uh,
Next slide.
Next slide. Thank you, Simon. Atherosclerosis in the heart, brain, and legs. Plaque buildup can block blood flow in many places. Smoking, high blood pressure, high LDL cholesterol, diabetes, and kidney disease all increase the risk. Lowering cholesterol, reducing inflammation, and healthy habits lower the risk.
So
Next
also,
slide, please.
also we know that there are infections that affect the heart. We know that COVID-19, influenza, respiratory syncytial virus can inflame the heart and trigger rhythm problems. The risk of a heart event is higher in the weeks following a severe infection. We know that vaccines can lower the chance of severe illness and heart complications, so we know that that should be done. And this slide is very interesting. Go to the next slide, the graphs. So this shows the number of decreased hospitalizations if you have a vaccine. But the other side, where you almost see nothing, is what happens if you did not get a vaccine. It does not cause inflammation. It's almost zero. Now, we know that there can be some inflammation, but it almost doesn't register at all. So that's pretty dramatic. You need to get a vaccination. I invite, as we go along, I want to read a comment as he sees fit going on. So heart failure medicines, devices, and procedures. We know that medicines, next slide. We know that medicines can reduce hospital stays and deaths as well. It's in common groups that affect us in medicine. There's the beta blockers that relax blood vessels, the medicines that help the kidneys remove extra salt and water. We know that Black people are more sensitive to salt, as are some brown people. We know that neuromedicines such as SGLT2 inhibitors also help the heart. Even people without diabetes, they can be used to help the heart and the brain. Some devices can help people, especially special pacemakers that resynchronize the heart and defibrillators that prevent sudden death. And I know Dr. Richard Williams has written books on sudden death in athletes especially. And we know in severe cases, a heart pump, a heart transplant can happen. One of the receptionists that I have in my office has a heart transplant that she got from postnatal delivery of her baby. She got heart disease and had to have a heart transplant. She dedicated her life now to young people. Next slide. So this looks at the risk reduction in medicines, and we can see that they're the angiotensin type drugs that can affect the risk reduction. The beta blockers are up there. The mineral corticoids such as Corindia are up there, and the SGLT2 inhibitors. And sometimes we use all those medicines at once. Next slide. Dr. Walks, will we take this one?
Sure. Advanced heart failure. Who benefits from procedures and devices? A resynchronizing pacemaker can help when the heart's timing is off. A defibrillator lowers the chance of dying from dangerous rhythms in selected people. A heart pump supports people with very weak hearts. Some later receive a transplant. Risks vary by person. Decisions are made by a heart team and the patient together. Next slide, please.
You can go ahead with this one, Dr. Walks.
Devices benefits in advanced heart failure. We're looking at some of the different devices along the lower axis, and the vertical line tells us how much benefit we get. So all of these show significant benefit and when used properly. And of course, the one that is the big granddaddy of all is the heart transplant, when the other things don't work well enough, and that is an opportunity to kind of start over again with a new heart. Next slide, please.
That's awesome.
Preventing future heart attacks and strokes, medicines. High intensity statins are the foundation for most adults with artery plaque. Ezetimibe and PCSK9 inhibitors can be added for people who need more cholesterol lowering. In some adults after a heart attack, low dose colchicine can reduce risk of future events. Daily aspirin is not for everyone. It can raise bleeding risk. Use only when your clinician advises it.
And let me comment on the colchicine too, and I welcome Dr. Williams to comment as well. Colchicine is very good as an anti-inflammatory agent, but has a very narrow window of efficacy. So I would not use that without hospital advice from my surgeon or my doctor, but it's especially useful post-operatively because that's a period of time when the heart can get inflamed, and can be a problem in people going forward. I invite the cardiologist to comment if he cares to on this. Next slide. And this is just graphical evidence to show you about high intensity statin, but a lot of people don't trust statins, don't like them. But I guarantee you, if you can take them and not have a reaction to them, they're very important in the treatment of heart disease and inflammation. And you can see that colchicine is also very much recommended, but all these can be used at once or in combination. Let's go to the next slide. So chest pain is from the narrowing of a heart artery. And there are certain medicines versus stents that can happen. Now, this chest pain doesn't have to be going down your left side, going down your left arm. It can be in your jaw, your back, it can be all kind of places. And I'll let Dr. Williams comment on that if he cares to. But it's not just chest pain, but it's pressure and can be seen, and especially not recognized in many women. I know Dr. Williams had one of the slides in the desk that says that many doctors think the woman should just be treated with a Tylenol, unless she's pregnant, of course. She can't take Tylenol according to the President of the United States. But be
Dr.
careful
Maxey.
about any discomfort and shorten the breath that happens. So also, we continue to recognize that lifestyle changes help many people feel better and lower the risk. A stent procedure can improve symptoms more quickly for some people with frequent chest pain. For long-term survival and stable disease, medicines and healthy living can remain the foundation. The choice depends upon what your symptoms are and what your test results are and your patient preference for that. And this is a slide, next slide. Next slide, Simon. This simply shows that people who have much less pain usually get a stent put in. So if you're having pain, don't suffer for months and years. Get it checked out and see if a stent will help you. Let's go to the next slide. Dr. Naaman Stevens, will you take this one?
Sure. Irregular heartbeat or atrial fibrillation, medicines and procedures. Blood thinners lower the chance of stroke for people with higher risk scores, which they have because of the atrial fibrillation. Treatment to slow the heart or restore a steady rhythm can improve symptoms. Ablation is a procedure that targets the short circuits causing the rhythm problem in some people. A left atrial appendage closure device, try saying that 10 times, may be an option for those who cannot take blood thinners.
And the reason people take blood thinners is why, Dr. Naaman Stevens?
Well, the reason they take blood thinners is to prevent the platelets from becoming stuck together and causing an obstruction, which can break off and cause the stroke.
Okay, take the next slide if you would.
Stroke risk lower with blood thinners. So the big fat column represents the risk chance of a stroke in people who are not taking blood thinners. And the shorter block is depicting the much lower risk in those patients taking a blood thinner.
Thank you very much, Dr. Wilkes. Next slide.
Heart valve disease, catheter procedures and surgery. Tight aortic valves can be treated by catheter valve replacement for many adults. Recovery is often faster than open surgery. Leaky mitral valves can sometimes be repaired with a catheter clip. Other times, surgery is best. Your heart team weighs age, fitness, and anatomy to recommend the safest, most effective approach. All procedures have risks. Discussion and shared decisions are essential. Next slide, please.
Take that one, Dr. Wilkes.
Decreased hospital stays, which we all want. So the typical hospital stay in days from bottom to top. So if there is a catheter valve replacement, your typical hospital stay would be shorter than if you have the open heart valve surgery. Again, not just because it's shorter, but discussion with your heart team to decide what's best for you is what's indicated. Next slide, please.
Dr. Lawson?
High blood pressure, medicine choices and results. Many people need more than one medication to reach a healthy range. Common choices include a diuretic, the calcium channel blocker, an ACE inhibitor, or an ARP. Average lowering of the top known as systolic varies by class and dose. Lifestyle means less salt, more movement, weight management, and good sleep. All of these produces much better success.
And take the next slide if you would also.
Average systolic blood pressure lowering. First one showing, of course, average low, very strong with diuretics, calcium channel blockers. Next come the ACE inhibitors and also ARP.
Mhm. So there also are genes. Next slide. Genes and heritage is important, and we also need fairness and care. We know that some heart conditions run in families, and we recognize that people need to have genetic counseling that can help these families plan testing and care. We know that people of West African heritage may carry a transrecent change that raises the amyloidosis risk. And some people with African ancestry have APOL1 kidney risk, which also affects the heart risk through kidney disease. We know that access to care, income, and neighborhood stress also affect outcomes in that. Next slide. We know that this gives you a thickened heart muscle with amyloidosis, and some people are born with a very thick heart muscle. Others develop a protein buildup called transurethral amyloidosis that stiffens the heart, and it's inherited in blacks as HATTR CD. We know that clues include thick heart walls. You can prove that by ultrasound, and you have low electrical signals that happen. Your EKG shows lower QRS waves, and you may get numbness or carpal tunnel syndrome. So if you see that, think about that and get tested genetically as well as with ultrasound. So next slide, chance of recent amyloidosis is a targeted treatment, and there's a drug called tafamidis, which stabilizes the transurethral protein and can slow disease progression. We know that there are gene silencing medicines for selected people that can lower the harmful effect of this protein by the liver. We know that early diagnosis does matter, and symptoms include thick heart walls, numbness, and carpal tunnel syndrome. We know that treatment can reduce hospital stays and improve quality of life. Go to the next slide. And this simply shows the use of the drug that decreases hospital stays per year. Dr. Walks, would you start with this slide? Next slide.
Cognitive effects of heart disease, understanding the heart-brain connection. Next slide, please. Mental health and the heart. Depression, anxiety, and post-traumatic stress can raise the chance of heart disease and worsen recovery. Treatment for mental health improves quality of life and may improve heart outcomes. Cardiac rehabilitation includes support for stress, sleep, and activity. Next slide.
Go with that, Dr. Walks.
Okay. Reduced blood flow to the brain. Atherosclerosis and heart failure can lower cardiac output. Chronic low blood flow impairs brain perfusion, may lead to vascular cognitive impairment and dementia. Next slide.
Dr. Lawson? Is he unmuted?
He is muted right now.
Go ahead, Dr. Lawson.
Okay. We'll try to get Dr. Lawson unmuted. Stroke and silent infarcts.
Got it.
Atrial. Oh, there we go. Go ahead, Dr. Lawson.
Stroke and silent infarcts. Atrial fibrillation increases risk of stroke. Silent brain infarcts damage memory and cognitive processing. Microvascular disease from hypertension/diabetes worsens cognition.
When I see that, Dr. Lawson, in many brains that I see of older Black people especially, there's a lot of white matter disease, and that affects the same thing from hypertension. You comment on that?
Yep, and I just want to note that a lot of white matter disease is also associated with increased risk of depression as well. And one point I just want to emphasize, and we talk about it later, is you didn't mention the role of substance abuse. Dr. Chapman and others have shown that many of these conditions are worsened by substance abuse, even in terms of stimulants and reducing blood pressure, as well as lifestyle changes that impact the heart.
Can you take the next slide, if you would, Dr. Lawson?
Cognitive decline and dementia risk. Heart failure and coronary artery disease are linked to mild cognitive impairment. The risk rises with diabetes, high cholesterol, and smoking. Dementia risk is higher in cardiovascular patients. And I just want to add to that, the evidence is now showing that even Alzheimer's is affected by some of these. And maybe it's just as important as genetic factors.
You take the next slide, if you would, too, Dr. Lawson.
Depression and mental health impact. Depression and anxiety are common with heart disease. They impair memory, attention, problem solving, and inflammatory and neurochemical changes worsen brain health. We might add that survival after MI is worse in people who have major depression.
And Dr. Walks, next slide.
Post-cardiac event cognitive changes. Cognitive issues may follow bypass surgery, heart attack, or ICU stays, which is exactly what Dr. Lawson just mentioned. Postoperative cognitive dysfunction may develop. These cognitive changes can range from short-term memory loss to lasting executive dysfunction. Next slide, please.
Go ahead, Dr. Walks.
Right. Cognitive domains most affected. Executive function, which includes planning, organizing, or multitasking. Attention and concentration, processing speed, short-term and working memory. Essentially, all the things you really need to function as a functioning adult. Next slide, please.
Dr. Neighbor-Stevens.
Ethnic and genetic factors. African Americans and Hispanics face higher risk of vascular dementia. APOL1 and other genetic variants may play a role. A higher burden of vascular risk factors increases your overall risk.
And take the following, if you would.
Food, movement, sleep, and habits. Choose Mediterranean or DASH-style eating patterns with vegetables, fruits, beans, whole grains, fish, and olive oil. Move most days and add simple strength workouts 2 to 3 times a week. Aim for 7 to 8 hours of sleep. Avoid tobacco and limit alcohol intake.
And go to the next one.
A simple prevention plan. Know your numbers. That would be your blood pressure, your LDL and cholesterol numbers, your blood sugar level, your weight, and your kidney test values. Use a heart risk calculator with your clinician. Consider a calcium score when the decision is unclear. Treat risk factors and include mental health, nutrition, and activity in the overall plan.
And next slide, please. So these are key takeaways. We know that heart disease affects both body and brain at the same time. We know that prevention is through controlling blood pressure, controlling your cholesterol, as well as your diabetes. A good diet is plant-based mostly. Exercise and smoking cessation is very critical in reducing the risk of cognitive decline. Next slide. So many heart attacks and strokes can be prevented by taking your medicine and paying attention to your diet and your exercise. Health habits plus the right medicines save lives. And I caution people not to change their medicines or stop them without talking to your physician. I have so many of my patients come in, oh, I stopped that 3 months ago. I don't know why I'm feeling so bad. Mind and body health are connected. Thank you very much. And I invite our honoree to make any comments on this cardiac lecture that he inspired and how people should better protect their health. Dr. Williams, you have a word?
Yes, I do. I, first of all, want to give you and the Black Health Trust Group credit for putting this together. This is a message that's going out to people to help them save their own lives, and give them some pointers from the experience that many of us have had in medicine over the years. So you're to be congratulated for doing this. And I just hope that people pick up on the take home messages in regards to how to help to improve their lives and help themselves to survive. One last thing that I'd like to say is that obviously you can't include everything into such a comprehensive coverage of cardiovascular disease, but I do want to emphasize the importance now of some newer cutting edge concerns that we have in cardiology, and in particular, the concern about lipid levels, certain lipid levels, that is the level of the blood fats. For a long time, we've had concerns about what you might call ordinary cholesterol levels, the LDL levels, high cholesterol levels, as we measure them ordinarily. But more recently, there's concern about a newer or a more recently discovered fragment called LP little a. It's lipoprotein small a, which is now regarded as one of the principal causes of morbidity and mortality from cardiovascular disease, and particularly from atherosclerosis. It's something that we can't give a great deal of discussion to today, but suffice it to say that hopefully people will wonder what this is, LP little a, and whether they should ask their doctor about whether they need to have it measured, because it's not simply anymore a matter of measuring a cholesterol level and finding that perhaps the cholesterol level is normal and that nothing else needs to be done or concerned about regarding the risk of having a heart attack or a stroke in the future. I encourage people to think that yes, there is something to be concerned about. There may be this hidden factor within you that can be picked up through special testing, and you need to ask your doctor about LP little a.
Can you relate that to any dietary practices that we love to eat in our communities?
No, that's an excellent question in regards to LP little a. There's nothing from a dietary or activity level that's going to affect it. There are new drugs that are being developed right now by some companies that are rushing to come up with a medication that will decrease it. And very specifically, it needs to be recognized that Blacks have a 70% higher incidence, as you might suspect, of having elevated LP(a) levels, which are a risk for heart attacks, strokes.
That's William Figure. One of the things I noticed in doing my research for putting this together, that women, a 20-year-old woman compared to a 50 or 60-year woman, the older woman has almost a 30 times more heart risk. And we discussed that. I mean, why are women so much more vulnerable to heart risk and heart failure the older they get, especially postmenopausal?
Well, and you hit on a great point. In one of my books, I described the reason for that, which is tied to hormonal levels, particularly estrogen levels. Women have an advantage from the standpoint of decreased incidence of heart attacks when they are younger, but they lose that advantage under two circumstances. Number one is when they grow older and they lose their estrogen protection. And number two is if they smoke. Smoking absolutely destroys that protection that they have, and their heart attack advantage, which is about 10 years over males at younger ages, disappears and decreases. So we can't keep women from getting older, but we can keep them from smoking and destroying that advantage that they naturally have.
Thank you so much. Dr. Neighbor Stephen, any questions or comments in the chat?
Yeah, there are. I'm glad we have a couple of minutes. There are a couple of questions, two or three. There was a request, well, two requests actually, regarding what the type and quantity of alcohol ingestion is significant when we're talking about reducing heart disease. And there were questions about pacemakers and any special concerns that dentists should have if a patient has a defibrillator.
Excellent questions all. Let's address them. So with the alcohol use, it's recommended that people drink as little as possible because there are risks, health risks, not only heart disease, but cancer that happen when you have alcohol. And whatever amount of alcohol that men drink, women should take even less. And because the use of bottles, body size is different, metabolism is different. But I think the recommended use of alcohol is less than 2 drinks per week. As I used to remember that. Any comments on that, Dr. Lawson, Dr. Walks, about drinking alcohol?
Yeah, we did a series of studies, one with a colleague of mine, just looking at this issue of animal research in humans. I think the point is there's a lot of been focus on chronic alcohol use versus what happens if you quotes binge drinker, and there's almost this feeling that if you only drink on weekends, you're okay. And what we found, and I was found, is the now finding is that binge drinking is not protected. Binge drinking is not protected. If you just drink on weekends or others and drink highly, then you still have the same kinds of cardiovascular and cognitive impairment risks that you have. The chronic drinking, of course, has an effect in terms of affecting diet and so forth. But the binge drinking can actually affect cognitive functioning and cause neuronal damage.
Any thoughts on that, Dr. Walks?
I don't think I've seen research that actually says if you drink this amount of alcohol, it'll have no negative effect. You should drink as little alcohol as possible. That's really the only safe recommendation because we keep saying, well, can I have can I have 2 drinks? Can I have 1 drink? Well, yeah, you can, but not with the guarantee that the alcohol is good for you, or is going to be helpful, or is going to be protective, or even that it's not going to be harmful.
That neighbor's even, what about drinking when you're pregnant?
Well, references
No.
to that go back to the Bible. So that has never been so. No, you all were laughing at me.
I'm not laughing at you. Go ahead. I'm laughing at Dr. Maxey's question. Go ahead.
Yeah, and there are certainly known effects of maternal ingestion of alcohol on the developing fetus. One of the more pronounced ones being something called fetal alcohol syndrome. And notably in that syndrome, there is not to this day a determination of a safe amount of alcohol that the pregnant woman can consume without risking damage to the fetus.
Dr.
And-
Maxey, can I weigh in on that?
Yes, sir.
Let me just note that also my colleague, CNBC's colleague, Carl Bell, has often made the point that variants of fetal alcohol syndrome is often underdiagnosed or misdiagnosed in the African American community, and probably a major contributor to some of the conduct and criminal problems we find in some of our correctional systems. We find that if you do a careful study, that probably some of the folks that are listed as criminals, in fact, have sequelae that's very similar to fetal alcohol syndrome.
Okay, Dr. Williams, you had a comment?
All right, I'd like to defer to Dr. Jessie Sherrod, who has her hand raised, and then I'll make my comment.
Dr. Sherrod? And by the way, congratulations, Dr. Sherrod. I heard about a library being named in your honor at the college and called Tougaloo.
Oh, thank you so much. It's an auditorium in the Bennie G. Thompson, Congressman Bennie G. Thompson and his Academic and Civil Rights Research Center. So it's the auditorium. It'll be the Sherrod Auditorium. Thank you so much for the congratulations. I appreciate all of the support. I have 2 questions. One concerning the role of inflammation. I know at one time we were focused mostly on the cholesterol and the height of the cholesterol, but I think inflammation plays a major role. And I don't know if you discussed that already, but how should we focus on decreasing inflammation? And then the second question I have is for Dr. Williams concerning the LPA, the LP little a. How does that fit into the risk of cardiovascular disease in view of inflammation?
Dr. Williams, want to answer that question?
Sure, but before I do, I wanted to go back to the alcohol conundrum and mention that I think that what Dr. Walks mentioned is absolutely right on target in regards to our knowledge of whether alcohol represents a risk or whether there is any level that is safe. Recent statistics from the National Bureau of Health Statistics show that there is absolutely no level of alcohol intake that is associated with no risk. In other words, if you drink even 1 drink, there is a cardiovascular risk. You are risking something regarding cardiovascular disease by drinking even 1 drink. And that has been recently revealed. Now, to Dr. Sherrod's question, first of all, starting off with the inflammatory proposition. It is widely believed by most cardiovascular specialists that inflammation is really at the root of almost all cardiovascular disease, period. And that every effort needs to be made to eradicate inflammation as the bottom line stratagem to try to make us risk-free. And as far as LP little a is concerned, what was the question, Dr. Sherrod, in regards to that?
how does that play into heart attacks in view of inflammation? And I just want to say also concerning the alcohol, they're now leaning toward recommending that no alcohol is safe. That's you gave the statistics. I actually had that in my mind, but then I got distracted. But
Okay.
that's true. But also, how does LILPA interact with inflammation and level of cholesterol?
To cut to the chase on that, it is now believed that it is the #1 villain in regards to causation of atherosclerosis. But it's hiding behind all of the big boppers that have been out there for so long, such as LDL and some of the other fragments of cholesterol. So LPA is something that you're going to hear much more about. At the present time, bear in mind that when you have your cholesterol tested, most likely the LP(a) level will not be reflected unless the doctor absolutely dictates that that be tested along with the other parts of your metabolic panel.
So we also know that inflammation is caused by these cholesterol fragments. We know that in APLO1 that one of the problems with that is it affects a type of HDL. So it's not only just the LDL, but all of these agents are somewhat inflammatory, and this is the basis of that disease. We know that many mineralocorticoids themselves are inflammatory. So almost all of these can be inflammatory. We know that insulin is inflammatory. So the whole process of degradation of body function is based upon inflammation, and any of these hormones in the wrong amount can be inflammatory. So I think, Dr. Sherrod, the basis of disease is inflammation in the heart, the kidney, and other places.
Yes.
Any other thoughts that we have in the chat, Dr. Neighbor-Stevens, you've seen?
Dr. Lawson wanted to make a comment or ask a question, and there is a question about plaque on heart valves.
Okay, Dr. Lawson, and then we'll let Dr. Williams answer the plaque on heart valves.
Yeah, I just wonder what the panel thinks about. There was a question raised about the role of energy drinks, and I just wanted to know what the thoughts of the panel about that.
Role of what?
Energy drinks. There are some people who there's evidence that some of our drinks, including are okay if the high dose caffeine is okay, and there's much more attempts to energize some of the more common beverages. But I'm just wondering what the thoughts about in terms of what that means in terms of heart health and also hypertension.
Okay. Dr. Williams, can I address a couple of those questions?
Very quickly, as far as the plaque on heart valve question is concerned, the question really applies to calcification which occurs on certain heart valves over a period of time, and particularly on the aortic valve as well as the mitral valve. But what this does is to compromise the integrity of the valve function. Valves function principally by opening and closing, opening to allow blood to flow through, closing to prevent backflow of blood. And if the valve becomes impacted by calcium, as it does over a period of time, it can't fulfill its function. And so heart failure may ensue. To prevent that, certain operations or procedures can be done. More recently, there's a procedure called TAVR, that's a transaortic valve replacement with a catheter, transcatheter replacement of the aortic valve, which eliminates the necessity of open heart surgery in certain individuals. About 80% of us will develop severe calcific aortic stenosis over a period of time, and we may not know it. I myself developed it, and I didn't know that I had it until I had a syncopal episode secondary to that. So it can occur to anybody, and especially to certain maybe cardiologists. It's something that we need to keep in mind. And the best detection is through uh, having your doctor doing examinations, which he is entrusted to do over the course of the time when you go for your physical examinations, which you should do on a regular basis.
Excellent. And as far as energy drinks, we know that energy drinks with high caffeine and high sugar can increase blood pressure, which is bad, can increase your chance of having arrhythmias, which is bad, and they're not good. There's something that should be limited or not used at all, especially if you already have diabetes or heart disease. It can be truly bad. And all of us like the taste of them, maybe, but they're not good for you. I can't think of any reason those energy drinks are good. I know that people, when they come in my office and their pressure is high, I said, "Did you have coffee?" Yes, I had coffee. So we know coffee can have some beneficial effects and help your mentation, but in an energy drink, it's super concentrated, and the results are hypertension, tachycardia, and decreased function of your endothelium and other problems that we won't go into now. So it's not good.
And they're not recommended for use in children.
Yes, sir.
Like me.
Yeah.
Dr. Williams and Dr. Lawson.
So two things real quick, Dr. Maxey. One, any particular points about pacemakers with dentistry? And then also Dr. Walt Baguette had his hand up.
Okay. Dr. Walks?
No, Walt Baguette.
Dr. Faggett, my teacher.
Hey, how you doing? Hey, I want to congratulate Dr. Williams on having a room named after him at the American College of Cardiology building this year, among his other accolades. And also looking forward to his big event this coming Saturday, the 11th of this month in Washington. So his awards continue. But I did have a question relative to the ranking of the outcome. Well, I know some people say bypass are a high risk for African American patients, but among all the procedures, which have better outcomes versus, or which have really the highest risk for African American patients? If you could comment on that.
And also, what's going on in Washington, D.C., Dr. Williams?
Well, on Saturday, October 11th, Dr. Faggett and I will be enjoying the 50th anniversary of the Association of Black Cardiologists, which I founded in 1974, and which has been responsible for saving thousands upon thousands, particularly of Black lives over this 50 years. So we're celebrating our accomplishments, and I'm quite proud of being the founder of that unique group.
So I think I was the first nephrologist to be a member, I think.
Yeah.
I wasn't a nephrologist yet in 74, though.
Yeah, but you were one of the first members. I recruited you.
Yes, you did.
Hey, maybe we get Buddy Guy to come play for you too.
That would be wonderful. What was the question about pacemakers?
Well, no, I was asking about the risk. Some people say bypass surgery is the outcomes among Black patients are not as good with bypass surgery. But in terms of other procedures, which have more risk for African Americans than other patients. First of all, is that been confirmed that there is increased risk or decreased better outcomes for Black patients with bypass surgery?
Well, we have worse outcomes whether we have procedures or not.
Right.
Just by virtue of being Black.
Right.
We in many cases are doomed to having bad outcomes.
Yeah.
And that's one of the things we've been trying to change through the ABC's efforts over these years. But in particular, as far as bypass surgery is concerned, there is no real worse outcome in Black patients. However, in Indian patients, that is Asian Indian patients, there may be a worse outcome, and it's this is a controversial issue, which I can't get into right now, but Asian Indian patients have smaller coronary vessels and are now being found to have an incidence of myocardial infarction due to obstructions, which rivals that of whites in this country and of blacks. And when they undergo cardiovascular procedures, they have worse outcomes because of that. So if that helps to give you some perspective.
Sure.
And the last question, Dr. Williams, if you could comment on is any specific concerns that dentists should have when working on their patients that have defibrillators.
Defibrillators, yes. I think dentists should have same concern that any of us should have in even touching a patient who has a defibrillator. Because if that thing should go off, not only does the patient receive a shock, but the contactant also receives a shock. And there are lots of stories that I could tell you about things like that. We don't have time. But I think the dentists may have some concern that perhaps they may incite the discharge of the pacemaker when they're doing procedures on their patients, especially using their instruments. There is no real concern there that the dentist should have. They're not going to set off the defibrillator by using their tools inside the mouth.
So I have this picture in my mind of this mafia guy with his boss in a dental chair, and he's got a gun. So if he suffers pain, you got a problem. Well, thank you, everybody. We're at the top of our hour. We appreciate you joining us. Let's go for final comments for the day. Let's start with Dr. Williams, our guest, and then go with Dr. Lawson.
I'd like to finish again by coming back to the beginning and congratulating you on putting together this program that elucidates some things for people about heart health and what they can do to help save their own lives, really, in conjunction with their doctors. And also to remind everybody that on December 7th, the Minority Health Institute is holding the 8th annual Imhotep Awards, principally to award Black doctors like Dr. Maxey received last year for their efforts in trying to uphold the health care of Black individuals and communities of color. So that's on December 7th. It's going to be at the California African American Museum. You should see something coming to your mailbox or your email box on that event, and we hope that you will attend and support our efforts to continue to help our folks to survive and to thrive.
Thank you, Dr. Williams. Dr. Lawson?
Yeah, I think it's pretty clear that one of the strengths of this program is that it shows that even though we talk about specific topics, we continue to emphasize that a specific topic has multidisciplinary impact.
Yes.
Including the brain as well as the rest. So a heart-brain linkage is very important. And the second thing is that even though we recognize the importance of looking at genetic factors and so forth, lifestyle is extremely important. And many behaviors that we consider okay, now that we're finding in the long term, can have serious and deleterious effects in terms of explaining some of these disparities that we talk about in terms of life expectancy, as well as our early events in our lives.
And thank you very much. Dr. Walks?
Thank you, Dr. Maxey. Dr. Williams, I just want to jump on the bandwagon with the acknowledgement of your contributions over the years. And if there's any reason to do a program like Black Health Trust and to talk to folks about preserving their health and linking preserving their good below the neck function with their above the neck function, It's looking at the fact that we've documented today over 50 years of you making profound, significant contributions to everyone's database about how we can take care of ourselves. And I don't want to belabor this too much, but I know that at 30 years in, we don't have the life experience to really understand all of the things we could contribute when we're 60, 70, or 80 years in. But if we can get folks at 3 and 5 years to begin understanding how important it is to preserve their health, what would we have missed if you had not been around to contribute for all of these years? I think that is what Black Health Trust is about. Black Health Trust is about highlighting the fact that if we can continue to care and function for long periods of time, man, you can't do everything in 20 years. You need time to accomplish all of that. And these programs give us information that allow us the luxury, the benefit, and the blessing of time to really fulfill our potential. So I think you're in like mile 3 of your marathon, Dr. Williams. So you just continue to run. You got a long way to go, brother. Thank you.
The marathon is 26 miles, isn't it?
26.2.
Oh, okay.
0.2.
So he's just getting started.
He's just getting started.
Well, I've run 8 marathons, and I don't think I'm about to run any more literal marathons, but the virtual marathons I'll continue to try to do.
Thank you.
Amen.
Dr. Barbara Navis-Stevens.
Thank you so much for joining us today, Dr. Williams, as an ardent supporter of our younger generations. My fear is that we are not effectively communicating
Yes,
to our younger generation
yes.
what we have accomplished and what still needs to be accomplished that they can step up and do. So I am happy that we had this discussion today, and I've been sitting here trying to think how this conversation can be spread to younger people interested in health professions or not, because the bottom line is we need to be advocates for our own health now more than ever.
Mm,
Excellent.
amen.
Thank you. And my final words are, we're going to have a program in the coming weeks on the increased heart risk and health risks of women. And I want to go into that in some detail. I think they're a special case. They have more problems and they're unrecognized in what those problems are and how we can address them. And also, we're going to have a talk from Dr. Virginia Kane. She's in mourning right now. She just lost her sister. And we have other people coming on with us, and we still have the talk on weight loss drugs coming up from the representative Noel Lardis coming up. And also thank Dr. Walter Faggett, who allowed me to go to Mississippi when I was a freshman medical student. We'll talk about that one day. Thank you so much. Thanks everybody for joining us. And
Sure.
Simon, thank you for helping so much. And tell us why this baseball player commentator got put in jail for fighting. I don't know who he is. Somebody.
Mark Sanchez.
Mm.
Mark Sanchez used to be the quarterback at USC and also for the New York Jets.
Okay.
It's still strange. Don't understand why they arrested him. He did get
I
stabbed.
think he was drinking alcohol.
Well,
Yeah.
they said he actually did the stabbing or initiated the stabbing.
Yeah.
More to come on that story.
So we always call alcohol ignorant oil. Thanks everybody. Thanks for joining us today. Thanks to the co-moderators and Dr. Williams. Honor to you again.
Thank
Have
you.
a great day.
Good day, everyone.
Bye.
Thanks,
Bye,
Simon.
everyone. Thank you.